on in our journey as a CCG, worked with NHS IQ to run the leading improvement in quality and safety in primary care programme, because we thought this would be a good thing to do to underpin our improvement work in terms of our statutory responsibilities to improve quality and safety in primary care. Making a link between our work with the LISC and how we've then gone on to run the Somerset Quality Practice Scheme, which Michael's going to tell you about, because it's all linked to our overall strategy for improving quality and safety in primary care. We launched the LISC in August 2013, and this was at an event, a joint event with our governing body and our COG, and that in itself was quite significant in that this was a whole day out for our clinical leadership team to think about quality and safety in primary care. NHS IQ came along and presented for the day and made the case for some changes. People sort of knew some of the issues that arose in their practices, but sort of didn't feel they knew how to make those changes. One of the things about challenging the assumptions about safety in primary care was to use this model. NHS IQ came along, and it's contested in some ways, but actually we found this, actually in terms of challenging assumptions about how systems linked to patient safety, was quite motivating for our leadership team and when we used it within practices. We spent quite a lot of time on the NHS Change Model. It provoked quite a lot of conversation and dialogue around the various aspects of the change model, and for this presentation I decided I'd look out the outcomes from that session with the clinical leaders, and actually I think some of the things that those clinical leaders got out of that session has very much helped inform our direction setting by our clinical leaders and embedded into the style of leadership. We had 14 practices, we have a federated model, and we have a total of 9 federations. We weren't able to get everybody involved at the beginning because actually we had that same problem that we've all talked about, is getting time away from the workplace to actually spend 5 days out at individual workshops. So we did have to financially incentivise people to come along. As well as having several GPs from practices, we also had their practice managers and some of their frontline staff who actually saw what impact they can have on safety themselves and actually empowered them to make some of those changes themselves. At the end we had a presentation about all of the things that they did, and actually it was quite inspiring. They'd all done quite a lot of stuff when you put it all together. For the individual practices that took part, I think they got a lot out of it. In terms of taking it forward and sharing it more widely, which was what was our initial plans around diffusion on a federated model, that hasn't been so successful. But it has built a foundation for sharing and learning together, because one of the things that we did get out of the LISC was an agreement to start our medication reporting in primary care. And that's beginning to really reap benefits. So in terms of the next steps, one of the things that we want to do is, and why I'm connecting it to the SPQS that Michael's going to talk about, is that we want to build on the learning within our federations in terms of sharing and learning, and make the tools and techniques available to the remainder practices to help them with other changes that they're making, and increase their capacity for change themselves. I think that segues into then what Michael's going to tell you about the Somerset Quality Practice Scheme.
Thanks, Karen. So I'm Michael Bainbridge, I'm Head of Primary Care Development at Somerset CCG. And as part of our approach to improving quality, we talked to GPs with NHS England about how they regarded quality in general practice and what the future held for them. And as you've heard from all the other speakers this morning, there's a real paradox between our aspirations for general practice and what it can deliver in relation to the 5-year forward view and those exciting models, and the place where general practice as a provider sector is now, which is heading downhill quite rapidly on a number of key measures, including patient satisfaction, vacancies, a workforce that's rapidly leaving, and so on. So with NHS England, as part of the primary care call to action, we engaged with member practices and asked them what they would like us to do to see happen. And one of the clear messages was that QOF, Quality and Outcomes Framework, which, as you probably know, is part of the GP contract framework, was having an inhibiting effect on the ability of GPs to provide the integrated person-centred care which they wished for. We were very lucky in Somerset to have an NHS England area team led by Anthony Farnsworth, who gave us permission to try and develop a local alternative scheme. So it wasn't easy or straightforward, but what we came up with was a really thorough process of engagement with GPs and other stakeholders. And what GPs in particular told us was that they wanted to focus their efforts on integrated care. And what they meant by integration was not organisational integration, but the process by which care for patients was joined up, seamless, and well coordinated. And what they told us was that every day they were seeing examples of that not happening. And there was also a sense that we needed to allow GPs the freedom to innovate. And again, that's a tension, isn't it, that we're all aware of. The need on the one hand to specify and to measure and to define quality, and on the other hand to allow people the space and time to experiment and innovate. And that's what we're doing in Somerset at the moment. So effectively what we did was to decouple practice income from achievement of QOF indicators. So in place of QOF, which you may know is a very, very detailed set of clinical indicators, we've instead asked the practices who are participating in this scheme, which is 3/4 of the Somerset practices, the others are remaining with QOF as you know, this is an entirely voluntary pilot. What practices are committing to is continuing to deliver good quality care, i.e. not stopping things just because the financial incentivisation from some clinical activities has been removed, to develop better integrated care for patients working with other providers, and that's across a whole range of things. So the examples are very wide. There's an awful lot of freedom in this scheme. So we've got some practices in rural West Somerset working on greatly enhanced end-of-life care model. We've got practices in some areas that are working on what are recognisably multi-specialty community provider and primary and acute care system models that you would recognise if you read the 5-year forward view, and all points in between. So people had freedom to decide what it was they wanted to focus on. But they're working together to develop more integrated care. And then finally, they're working with other practices to develop a sustainable business model. And in each of these 3 areas, they're getting support and help from CCG and NHS England. So it's very simple. In place of QOF, which is very complicated, this is essentially a side of A4 that people are signing up to. But it's quite profound. And we think these are the things that we want GPs to be concentrating on in Somerset. The money stays the same, so the funding going into general practice is the same whether they're doing QOF or SPQS. And there's quite a thorough evaluation, which we're getting the first outputs from now, and suggests that it is possible to take away the financial incentivisation of clinical processes without it having a detrimental effect on patient care. It has sparked a wave of innovation, and I think that's not just because people have got the freedom, but actually because general practitioners felt that they were being listened to. So for GPs in Somerset, I think it was quite powerful for both NHS England and the CCG to say, yeah, okay, we'll try that. I think, as Karen said, the CCG has wanted to have a role in the improvement of quality in general practice from the very early days. I think we're still trying to work out in practice what that role actually looks like and how we can best support our member practices. But it's certainly something that we've fully committed to as a CCG.